Bismillah ar-Rahman ar-Rahim. I am Dr. Mostafa Mokarab, Professor of Cardiology at Azhar University, and it's my pleasure to be with you for discussing a very important topic, which is non-ST elevation myocardial infarction. As you know, non-ST elevation myocardial infarction is a part of acute coronary syndrome, which include unstable angina, non-ST elevation myocardial infarction, or ST elevation myocardial infarction. And you will find this slide in guidelines ACS, acute coronary syndrome. A for abnormal ECG. You may have normal or abnormal ECG with typical anginal pain or typical cardiac pain. And this is a clinical context for the patient. For C, consider the clinical context and available investigations you can perform to your patient. And C, look for your patient is stable or unstable, and this will decide your decision either for immediate or delayed management. This is very important for assessment and initial examination for your patients with non-ST elevation myocardial infarction. If you look for ECG, you may have a normal or near normal ECG or non-specific STT wave changes with negative cardiac biomarker and typical cardiac pain. This is called unstable angina. Or you may have non-specific or specific STT wave changes or even normal ECG with positive cardiac biomarkers, especially high sensitive troponin. This is non-ST elevation myocardial infarction. And on the other hand, you may have ST elevation in ECG in different limb or pericardial lead. This is called Nstemi, ST elevation myocardial infarction, and this is different entity. And you may have normal or non-specific ECG changes with non-specific or negative cardiac biomarkers. This is called non-acute coronary syndrome diagnosis. For the patient with cardiac or locks cardiac chest pain, and we need another test to document either this is true cardiac chest pain or not. We have a high sensitive troponin, and this is very, very important. And according to rule in or rule out pathway, we have 0 hour, 1 hour, and 2 hours rule in, rule out pathway for your patient coming with cardiac or locks cardiac chest pain and cardiac biomarkers withdrawn. You may have very low initial high sensitive troponin or low initial high sensitive troponin and no increase in 1 or 2 hour test. This is rule out pathway, and this patient will undergo further investigation, non-invasive in nature. But on the other hand, you may have high initial high sensitive troponin or increase in 1 or 2 hour test. This is rule in pathway. And after rule in pathway, you can decide according to clinical context and available investigation and further clinical assessment. This is for either early invasive or conservative management. And you may have a patient with cardiac chest pain, looks typical cardiac pain, but we have non-specific rising or negative cardiac biomarkers in 0, 1, and 2 hours. This is observational pathway, and this patient especially need a specific attention, because your analysis for such type of pain will decide the next step, either rule in pathway or rule out pathway. This is for your assessment, for clinical judgment, and for further analysis, either by repeating test again for high sensitive troponin, or will observe these patients for either rule out or rule in pathway. Another Very important topic for our non-ST elevation myocardial infarction patient is think invasive management. For very high risk patient, as we will see later on, immediate angiography plus PCI is needed, and for high risk, early less than 24-hour angiography should be considered. And think according to coronary angio for revascularization. Remember, our aim in non-STEMI is complete revascularization, not like STEMI patient. STEMI patient, our aim is culprit only till now, and complete revascularization with an index of hospitalization or within 45 days after infarction. But for non-ST elevation myocardial infarction, complete revascularization is our aim. But consider adjective tests to guide revascularization. You may use intravascular imaging or intravascular physiology like IFR and FFR to decide which lesion is significant and need revascularization, and which lesion is moderate in nature and follow up only and medical treatment is needed. And remember, intravascular physiology not valid in patients with STEMI, but valid in patients with non-ST elevation myocardial infarction. Another important topic is secondary prevention after stabilization of your patient. Assess his general condition and apply secondary preventive measure in the form of antithrombotic therapy, lipid-lowering therapy,